Hello guys, this is Dr. Asif. As the previous video you have seen the head neck region, so this is the part 2 and the rest of the head neck topic about the MRCS study with me, the anatomical portion. So let's start. The circle of wheel is the vascular system of the brain. There are two internal carotid arteries and two vertebral arteries from anastomosis to form the circle of Willis. So two posterior cerebral arteries, they're united to form the circle of Willis. So here are the branches, and these arteries are anastomosed or connected with each other by anterior communicating artery, anterior cerebral artery, internal carotid artery, posterior communicating artery, posterior cerebral artery is the termination of the basilar artery. So what are the branches of those things? That is vertebral arteries, which is the branch of the subclavian artery and form the basilar artery. Okay, so they enter the cranial cavity via the foramen magnum and lie in the subarachnoid space and the relation with the base of the bones, and the branches will be the posterior spinal artery, the anterior spinal artery, and the posterior inferior cerebellar artery. So these are three important branches which is derived from vertebral artery. Another one is a basilar artery, so these are some branches, like this is the basilar artery and there are some lateral branches here like pontine arteries, superior cerebellar artery, posterior cerebral arteries, labyrinthine artery which will give supply to the air, and the anterior inferior cerebellar artery. And the internal carotid artery, that is here you can see the internal carotid artery in this region, these two things, and these have some branches: posterior communicating artery, anterior cerebral, middle cerebral, and anterior choroidal, which will give supply to the ventricular system, that is CSF, where CSF is formed. That system will be supplied by the anterior choroidal artery. Now there are some important topics about the vertebral arteries. Is the first branch of subclavian artery. You must remember there are four regions. Is superior part start from the transverse C6 and enter to the part of the vertebral and internal jugular vein. On the left side, thoracic ventilation, no need. The second part runs superiorly through foramen of the transverse cerium. That means this is the first part and this is the second part. Second part goes through the foramina transverse. So there have some foramens of each cervical vertebra. So it goes through it. And the third part of the run posteromedially on the lateral mass of the atlas. Posteromedially to the lateral mass of the atlas. So here the lateral mass of the atlas is laterally jai. It enters the suboccipital triangle. It enters the suboccipital triangle in the groove of the upper surface of the posterior arch of the atlas. The fourth part passes through the spinal dura and the subarachnoid, running superiorly and anteriorly at the lateral aspect of the medulla oblongata. And the lower border of the pons is united basilar artery. So these vertebral artery forms the basilar artery, and its fourth part passed through the spinal dura and arachnoid, running superior and anteriorly at the lateral aspect of the medulla oblongata. You must remember these three underlying portions. So these underlying portion must be remembered for MRCS Part A exam. Now the common carotid artery. So there the right common carotid artery arises from the bifurcation of the brachiocephalic trunk, and the left common carotid artery arises from the arch of the aorta. Okay, and both the terminate at the level of the superior border of the upper border of the third carotid C3 and 4, and by the dividing into the internal and external carotid arteries. The right common carotid artery arises from the brachiocephalic trunk. We all know that it is the topic of first year. And the left common carotid artery arises from the arch of aorta and the terminal of the C3 and 4. Okay, C4, it is the demarcation where the internal carotid common carotid artery becomes subdivided into two. One is internal carotid and external carotid. So that is C4. Okay, so C4 is very very important rather than, and C3 in this level high weight bones present here. Must remember. Okay, for part A exam. Left common carotid artery immediately left and slightly behind the origin of the trunk. Thoracic portion 2.5 to 3.5 centimeter, and the vessel is in contact from below upwards, and the trachea left laryngeal left margin of the esophagus. No need. And the posterior, the sympathetic tendon lies between the vessel and the prevertebral fascia. Okay, so it's very important. And it lies within the carotid sheath and the vagus nerve and internal jugular vein. Okay, so vagus nerve, internal jugular vein, and most medially that is internal carotid artery, and posteriorly the sympathetic nerve lies between the vessels and prevertebral fascia. These things must be present in the FCPS exam. In the part 1 exam, I faced this question. What is the structure lies posterior to the internal carotid, common carotid artery? So that is sympathetic trunk. At the level of C7, the vertebral artery, the thoracic duct lie behind it. Okay, C7, thoracic duct lie behind it. And the anterior tubercle of C6 transverse process is prominent, and artery can be compressed against the structure. Okay. Anteriorly at the C6, the omohyoid muscle pass superior to the artery. Within the carotid sheath, the jugular vein lies lateral to the artery. Okay. The carotid sheath, the jugular vein lies lateral to the artery. So first carotid sheath, then vagus nerve, the jugular vein. Okay. Now the right common carotid artery. The right common carotid artery arises from the brachiocephalic trunk, all with the same things. And the esophagus is less closely related to the right carotid than left. Upper border of the thyroid cartilage to divine external and internal carotid artery. So the upper border of the thyroid cartilage is also the divisional point of external internal carotid artery, because it lies in the C6 level. At the level of C6, vertebra crosses the omohyoid muscle, and the left common carotid artery crosses the thoracic duct, and the right common carotid artery crosses the recurrent laryngeal nerve. Must know. These two lines is must know. And the carotid tubercle transverse C6, and the compression of here stops Hugh, and thyroid artery passes posterior to the communicating inferior thyroid artery passes posterior to the anterior carotid artery. These things is very important because the relationship must be asked in the exam. Now the internal carotid arteries. The internal carotid artery form the common carotid opposite the upper body of the thyroid cartilage. We all know that, and enter the skull via the foramen canal, that is foramen lacerum. So carotid canal, which is also called the foramen lacerum, and the carotid canal then pass through the cavernous sinus, yes, and enter middle cerebral artery. Okay. So these are the relationship. Posteriorly longus capitis prevertebral fascia, and this is very important. Sympathetic chain actually, which lies posterior, and the medially external carotid near origin, and a pharyngeal artery. Oh, sorry, pharyngeal artery, and the external carotid artery near this origin, and the laterally internal jugular vein moves posteriorly at the entrance to skull vagus nerve, most posterior laterally. So posterior lateral vagus nerve and internal jugular vein most posterior at the entrance of the vessel skull. So these relationship is confusing, but you have to recapitulate by watching the picture. Okay, you have to see the picture from the Nature's clinical anatomy or the Nature's uh, diagrammatic pictures. So anteriorly, sternocleidomastoid, lingual and facial vein, and hypoglossal nerve. Most anteriorly, mimic for the branches of the cerebral portion, only press carotid artery momentarily. That is ophthalmic, posterior communicating, choroidal, anterior cerebral, middle cerebral. So these are the branches of the internal carotid artery. Okay, ophthalmic, posterior communicating, choroidal, anterior cerebral, middle cerebral. Okay, and the relationship of the carotid canal, that is internal. No need here because this things is not asked. This is the same things. The internal carotid does not have any branches in the neck. Okay, nerves at the risk during the carotid endarterectomy, that is hypoglossal. You must know hypoglossal, greater auricular, superior laryngeal, and vagus. So these four structures is in risk during endarterectomy operation because most commonly injured is hypoglossal nerve and the greater auricular nerve. Okay, because it lies just under the mandible or the angle of the mandible, that is the greater auricular nerve is usually injured, and also the superior laryngeal and vagus also. Now the external carotid artery. The external carotid commences immediately lateral to the pharyngeal side. It ascends and lie anterior to the internal carotid and posterior to the posterior belly of digastric and stylohyoid muscle. And the more inferior, it is covered by sternocleidomastoid past hypoglossal nerve and lingual and facial vein. Surface marking of the carotid. That is, there are three branches of the external carotid: three in front, two behind, and deep ascending pharyngeal. Okay, and two behind occipital and posterior auricular. And in front, the superior thyroid, lingual, and facial. Okay, lingual, facial, superior thyroid. These three are important. Front branch, two is occipital and posterior auricular, are deep ascending pharyngeal. So if you want to memorize it, there is a mimic. There is some angry lady figured out PMS. Superior thyroid, this is the first branch, and the ascending pharyngeal, deep branch, lingual, anterior branch, facial, tonsillar, labial artery, occipital, and posterior auricular, and maxillary, that is inferior alveolar artery, middle meningeal artery. Those all come from the special middle meningeal, which is come from the maxillary artery, and the superior temporal. It gives supply to the exterior of the scalp. So now the middle meningeal artery, it is surgically is very important vessels which gives supply to the meninges in the parietal region. So middle meningeal artery typically third branch of the maxillary artery. Okay, one of the two terminal branches of the external carotid artery. After branching off infratemporal, it runs through the foramina spinosum to give supply to the meninges. So this is foramina spinosum. Lacerum for internal carotid and spinosum for middle meningeal artery and some meningeal vessels. Meningeal artery is the largest and three paired arteries that supply meninges and other being anterior meningeal artery and posterior meningeal, and it is middle meningeal. So three important branches. Middle meningeal runs beneath the pterion, are vulnerable to injury in this point where the skull is thin. Here, the pterion here. Because this is the area where it is usually injured because it's a very thin area. So the millimeter runs dura matter surrounding the brain makes the deep indentation of the calvarium. The millimeter artery intimately associated with the auriculotemporal nerve, which wrap around the artery to easily identifiable dissection of the human cadavers. So during middle meningeal artery, is there any nerve which can be injured? That is auriculotemporal nerve, because it is very important for surgical importance, because sometimes there is an injury of auriculotemporal nerve. This keeps supply. It lies just inferior to the tragus of the ear. So this is the pterion. So this is the middle meningeal vessels. Okay, the posterior, anterior, and the middle. So this is the pterion, usually rupture here. Now the brachiocephalic artery. So brachiocephalic artery is the larger branch of the arch of aorta, and there is some relationship. Anteriorly sternothyroid, thymic remnants, left brachiocephalic vein, right inferior thyroid veins. Because inferior thyroid veins comes from brachiocephalic trunk. Okay, brachiocephalic trunk, cephalic artery. So you must know. So this lies in relation the brachiocephalic vein, and it gives anterior branch, and the posteriorly trachea and the right pleura and the right brachiocephalic vein and the superior part of this superior vena cava, and the left lateral thymus remnants, origin of the left common carotid, inferior thyroid veins, and trachea. Normally, none but have the thyroidema artery. It is occasionally present in some guys, but not all. So these are the relationship you can see here to know the relationship better than ever. Now the subclavian artery. Left subclavian artery comes directly from the of the arch of aorta. The right subclavian artery arises from the brachiocephalic trunk, bifurcated subclavian artery, right common carotid artery. And the subclavian artery travels laterally, passing between the anterior and middle scalene muscles and the deep to the sclerus anterior and the sclerus medius. As the subclavian artery crosses the lateral border of the first rib, it becomes the axillary artery. At this point, it is superficial and within the subclavian triangle. Now here, vertebral artery, internal thoracic artery, thyrocervical trunk, costocervical trunk, and dorsal scapular artery. Vitamin C and D, that is vertebral artery, internal thoracic, thyrocervical trunk, costocervical trunk, and dorsal scapular artery. It is very important because there are some MCQs, because which one is derived from the subclavian artery or the thyrocervical trunk. Thyrocervical trunk comes from which artery? It's sometimes asked. That is subclavian artery. Now internal jugular vein. Each jugular vein begins in the jugular foramen, and where they are continuation of the sigmoid sinus. Okay, and united to form the terminate medial end of the clavicle where the unit subclavian vein. So this is other things. Subclavian vein is the original draining points. The vein lies carotid sheath through below the skull. Internal carotid last for no need lies posteromedially. The vein overlapped by the sternocleidomastoid and covered by at its inferior aspect of the vein. Left side related to thoracic duct. At the midpoint, it crosses by the inferior root of the ansa cervicalis. Ansa cervicalis is the nerve which present in the carotid triangle. Here are the lymph nodes. External jugular vein runs obliquely in the superficial fascia of the posterior triangle. Okay, it drains the subclavian vein ultimately. And the third part and not the second part of the subclavian is not also a content of the posterior triangle. That is, third part of the subclavian artery is the content of the posterior triangle. These are all about the vascular system, and now the important cranial nerves. Okay, so there are 12 pairs of cranial nerve, 12 cranial nerves. That is, you can see here from the very beginning, from the 1 to 8, olfactory, optic, and the vestibulocochlear. These are the pure sensory. So these are the pure sensory. So maybe injury, the basal skull fracture. So we know, we also know that you all know about the namings, but for MRCS, the surgeons usually wanted to know that how many clinical parts or clinical importance you have gathered the knowledge about it. On the other hand, You can identify what is the answer, but you can't proceed because you don't know the clinical scenarios of you can co-regulate by practicing the uh, most important clinical symptoms or clinical relationship about the basic, because everybody know about what you have given your effort in front of the patient. Okay, so you must know the each and every nerves by their clinical scenarios. So because the basal skull fracture, usually olfactory nerve is injured because it involves a frontal lobe tumor extension, loss of olfactory nerve function, major CNS pathology, seldom pathology. So it is important things that a basal skull fracture is the cause of olfactory nerve damage. Now the optic nerve problems, the visual acuity may result in intraocular disorders. Problems may be in the blood supply. Amygdala's fuvux may be used to temporary visual distortions. Surgically, the pupillary size may be altered. Number of disorders, nerves involved in the resizing. People connect to the protectal nucleus in the high midbrain, bypassing the lateral geniculate nucleus and the primary visual cortex. From the pretectal nucleus, neurons pass to the Edinger-Westphal nucleus. Now the motor axons from here pass along the oculomotor nerve, the synapse with the ciliary ganglion. The parasympathetic axons from then innervates the mitotic pupil is seen in the disorders such as Horner's syndrome or opiate overdose. Now the mydriasis is the dilatation of the pupil in response to disease, trauma, drugs and dark. It is pathological, then light fails to induce meiosis. So these are the things of optic neuritis. Then shining of the light affected to produce no response. So consensual and light reflex related problems may be related with the optic nerve damage. Oculomotor nerve. It is one of the important third cranial nerve. So these are also the mixed nerve. So lateral rectus and the superior oblique muscle of the ocular region will supply the oculomotor nerve. 3, 4, 6, 11, 12 are the pure motor. So this is a pure motor nerve. This affect devial inferolateral. Pure motor. It gives supply the levator palpebrae superioris. May be impaired during impaired ability to open the eye. So we blink, usually blinking or a movement of the eyeballs maintained by the oculomotor nerve, and the trochlear nerve, the eye will not be able to look down. Trigeminal nerve, largest cranial nerve, and exit the brainstem at the bones. So it has three important branches: ophthalmic, maxillary, and mandibular branches. This is mixed nerve. No, this is also motor. 3, 4. Corneal reflex, and ciliary branch, ophthalmic, trigeminal, sensory components, and the facial nerve is the motor component. So this is a mixed nerve. I already told you the mixed nerve, and because ophthalmic vein has a sensory component, but facial nerve produces a motor response. Only the mandibular branch has both sensory and motor fibers. So mandibular branch has mixed, and the nasociliary branch, ophthalmic, is a sensory. Abducens nerve. It has a long cranial courses. Long cranial courses so render susceptible to damage in the intracranial pressure. So in case of raised intracranial pressure, abducens nerve can be damaged or injured. In that case, superior oblique muscle will be impaired. Now the facial nerve emerges bend stability in pons and medulla. It comes form. Control muscles of facial expression and the taste and to two-thirds of the tongue. Now passes into petrous temporal bone. Vestibulocochlear nerve exits the pons and passes through the internal acoustic meatus. It is a sensory neural hearing loss. It is implicated in the sensory neural hearing loss, that like meningitis, like osteosclerosis, some autotoxic drug, like gentamicin. So renal test will be reduced at the affected site, should still work. Overtosis is normal. The glossopharyngeal nerve exits the pons above the vagus, receives sensory fibers posterior one third of the tonsil, pharynx and middle. Otalgia may also following tonsillectomy operation. So glossopharyngeal the most posterior part of the posterior one third of the tongue. Both general sensation and special sense. It also gives supply to the parotid gland via the otic ganglion and the motor muscles, the stylopharyngeus muscle. Sensory is the gag reflex. Okay. Now the vagus. Vagus is the largest parasympathetic fibers because middle of the olivary nucleus and inferior cerebellar peduncle. Passes jugular foramen into cranial sheath. Detailed functions of vagus nerve are covered by website. No need. Accessory caudal part of the brainstem. Supplies trapezius and the sternocleidomastoid. That is spinal component of the accessory nerve. And the hypoglossal nerve it gives damage in the endarterectomy surgery. Near the carotid makes vulnerable during carotid surgery and the gives supply to the intrinsic muscles of the tongue, except palatoglossus. These some parasympathetic fibers, the 3, 7, 9, 10. So oculomotor, facial, glossopharyngeal, vagus. So these three craniosacral. So this is the cranial region for cranial parasympathetic component, papillary constriction and accommodation, facial, lacrimal, and submalleolar, sublingual by pterygopalatine ganglion, parotid by otic ganglion, and the vagus by the heart and abdominal viscerus, oculomotor by celiac ganglion. So these are the brainstem and their components, which is came from different root of nerves, all by, optic, olfactory bulb, oculomotor, and the trochlear trigeminal. Trigeminal is a more fat and huge distended trigeminal nerve root, wide, very wide. Then abducens, then facial. So cerebral that is pons and the medulla oblongata in between. There are some different kind of nerve system came out through this junction. So this is the hypoglossal. Now the trigeminal nerve. So there are some sensory and motor component: skull, face, nose, and sinus sensory. That is ophthalmic division, motor division, is maxillary, mastication, anterior digestic, the mandibular region. So maxillary, mandibular, motor, and the olfactory and sensory. Autonomic ancillaries, sphenopalatine, otic, and mandibular. So these are the autonomic ganglions. Ophthalmic sensory, maxillary sensory, but mandibular mixed. So these are the three important trigeminal nerve to the skull. That is superior orbital fissure, that is ophthalmic nerve, maxillary division, foramen rotunda, and the mandibular region, foramen ovale. So these three fibers came through these foramens of skull: rotunda, maxillary, ovale, mandibular. So trigeminal nerve is a major sensory nerve to the face, except over the angle of the jaw, which is supplied by the greater auricular nerve. And the motor, the masseter, temporalis, medial pterygoid, lateral pterygoid, and the other muscles, tensor veli palatini, omohyoid, anterior belly of digestic, and tensor tympani. So these things, motor supply gives supply by the mandibular division of trigeminal nerve. Now the facial nerve. Facial nerve is the main nerve supplying the structure secondary embryonic branch. Second, branchial arch. It is predominantly an efferent nerve of the muscle of facial expression. digesting muscle and also many glandular structures. Supply the face muscle of facial expression, nerve, stapedius, taste supply the anterior tooth of the tongue, and the parasympathetic fibers of lacrimal also salivary glands. Origin motor pons and sensory nerves. Facial canal, so gator, petrosal nerve, nerve to stapedius, and chorda tympani. This is a facial path. Stylomastid foramen pass through the stylomastid foramen, first branch of the facial nerve. Then it gives five important branches: temporal branch, zygomatic, buccal, marginal mandibular, and E cervical. Temporal, zygomatic, buccal, marginal mandibular, cervical. The chorda tympani branch now towards the canaliculus of middle ear and crosses the middle aspect of the tympanic membrane. It also gives supply to the anterior two-third of the tongue, sensory supply. So this is the chorda tympani branch. These three are which one is keep supplied V3 mandibular division keeps supply mix sensory and motor presented to the chorda tympani. That is chorda tympani is came from the mandibular division V3 and that is sensory portion, and motor portion gives supply to the muscles. Now the vagus. So vagus has a mixed function supply structure, fourth and sixth arches. It supplies the foregut and midgut section of the embryonic gut tube, pharynx, larynx, esophagus, stomach, heart, and great vessels. And second type of urinary nerve, direct skeletal muscle innervation. And these are the largely muscle of the larynx and pharynx. Origin of the course is the vagus arises from the lateral aspect of the medulla oblongata by a series of roots. It exists through the jugular foramen as a content within its own sheath alongside the accessory nerve in the neck. It descends vertically in the carotid sheath where it is closely related to the internal and common carotid arteries, leaves the neck and enters the mediastinum. On the right, it passes anterior to the first part of the subclavian artery. On the left, it lies in the interval between the common carotid and subclavian arteries. In the mediastinum, both nerves pass posterior inferiorly and reach the posterior surface of the corresponding lung roots. At the inferior end of the mediastinum, these plexus unite to form the formal vagal trunk, pass through the esophageal hiatus and abdomen. That is anterior and posterior vagal trunk. Okay, so vagus comes through the posterior region, left vagus, which is from the recurrent laryngeal nerve, arch of the aorta, which hooks around the arch of the aorta in the right side. It hooks around the subclavian artery. Now the superior inferior ganglion. Not so necessary here. So arises anterior and the first part of subclavian hook under it and ascends superior medially. And superior inferior cervical cardiac branches arises from various points. Thorax on the right side, this pass posterior to the artery and connect to the deep cardiac plexus. And the left recurrent laryngeal arises from the vagus and aortic hooks around the inferior surface of the arch and posterior to the ligamentum arteriosum and passes through the superior mediastinum and lower part of the neck, lies grooved. Between the esophagus and supply both no need. The thoracic and cardiac branches are extensive branch. Both roots pass through the both lungs and viscera. Anteabdominal nerve branches extensively And the previous paired extensive network of the distal branches nerve of bladder jet, the surface distal stomach were highly selective vagotomy. So this is not usually done because in the use of modern people reduce the need for highly selective procedures. So this gives supply to the sympathetic parasympathetic system. Right and left recurrent laryngeal nerve, very important, arises from the anterior to the subclavian artery and the obliquely next to the trachea and the left to arch of the wings below the aorta. Enter the larynx behind the articulation between thyroid cartilage and cricoid cartilage because it's called the ligamentum berry. Enters the larynx between the articulation between thyroid cartilage and cricoid along the ligamentum berry. Cardiac plexus, intrinsic muscle of the muscle, supplied to the recurrent laryngeal except cricothyroid. See here, these supply the cricothyroid muscles supplied by another one, and these superior and inferior pharyngeal nerve, internal laryngeal nerve and external laryngeal. Internal laryngeal gives supply to the vocal cord. External laryngeal nerve gives supply to the intrinsic muscle of the larynx. So ansa cervicalis একটা হলো anterior nerve supply to the inferior strap. Large goiter muscle should be divided in the upper half. During radical neck dissection, division of the pretracheal fascia will expose the ansa cervicalis. So pretracheal fascia will expose the ansa cervicalis. You must know the things. Now the ear anatomy. The ear is composed of three important distincts. Though first things you must know that in the MRCS Part A exam there is another one is Part A DOHNS exam. So recently there is an incident that DOHNS questions is merged with the MRCS Part A question. That's why some young junior surgeons they complained about some embryology and some head neck related question is more in the exam. Because of why it happens, because DOHNS has no part 1 exam. They must appear in the MRCS Part A to qualify for DOHNS Part B exam. That's why you can't ignore the I and ENT parts. So you must focus there also. Okay, the external carotid meatus 2.5 centimeter long. The auricular temporal nerve supplies most external artery meatus and the lateral subauricle. It is very important. Auricular temporal branch of mandibular division of trigeminal nerve. And sensory is greater auricular nerve. Okay, motor is auricular temporal nerve. So there are three parts: outer stratified, middle layer of fibrous, and inner layer of mucus. That is, tympanic membrane has three layers: outer, middle, and inner. And the chordae tympani inner passes through the medial ossa plus flaccida, not pars tensa. It's flaccida. The middle layer is innervated by glossopharyngeal nerve. Pain may radiate to the middle ear following tonsillectomy operation. So this is the tympanic membrane. So this is the handle of malleolus. This is the membrane. So internal cochlea, semicircular canals of vestibules. Organ of Cordy is a sense organ hearing and located on the inside of the cochlear duct in the basilar membrane. And the vestibule accommodates the utricle and saccule. These contains the endolimb, which is surrounded by the perilimb. Endolimb contains more potassium and the perilimb contains more sodium. Semicircular canal lies various angle of a petrous temporal bone. All shares the common opening of the vestibule. So these are the common opening of the vestibule. This is the semicircular canals and this is the cochlea. vestibular nerve, that is internal acoustic meatus, vestibular facial nerve, that is chorda tympani branch, and the vestibulocochlear branch. These two things are came through the internal acoustic meatus, and this is the cochlea, hearing capability, and this is the motion capability. That is changes of motion or sight, which will help by utricle and saccio. And it has organ of Corti, hair cells of organ of Corti, so it contains some hearing capabilities, and endolimb and perilimb. So there are some fluids or extracellular fluids which is moving, and the motion is maintained. So the missing is the middle ear cavity. So tensor tympani muscles and the chorda tympani nerve, and this is the mastoid antrum. So there is a mastoid cavity here, and the semicircular canals, and the pyramidal eminence, and gives sympathetic branch of the Brachiocephalic nerve, and laser petrosal nerve, and branch of the internal carotid vessels, and sympathetic plexus. This is the internal jugular vein. So this is roof of the internal jugular part. Lacrimal system. So lacrimal branch ophthalmic artery and the venous drainage ophthalmic vein. Consists of orbital part of palpebral nerve composed to lateral around the concave lateral edge of the levator palpebris superioris. And the gland is innervated by the secretomotor parasympathetic fibers from the pterygopalatine ganglion, which may reach the gland via the zygomatic and lacrimal branch of the axillary nerve directly to the gland. Geniculate ganglion gives supply to the lacrimal, maintaining of the lacrimal vessel. That is also pterygopalatine ganglion or geniculate ganglion. Here, the pterygopalatine ganglion. Nasolacrimal duct descend lacrimal sac open inferior meatus of the nose. Parasympathetic fiber relay pterygopalatine ganglion. Efferent signal pass greater petrosal nerve, and the posterior ganglion sympathetic fibers, and the sympathetic fibers do not synapse, they turn to relay lacrimal apparatus. Okay. Now the tonsil. There are arterial supply from the tonsillar artery and the branch of facial artery. We all know the tonsillar artery is the branch of facial artery, and it is also the external carotid artery branch. It veins constrictor external palatine facial vein may result hemorrhage during the tonsillectomy, that is external palatine vessel is the culprit. External palatine vein sometimes open, and so the recurrent hemorrhage may also called reactionary hemorrhage. So there are jugular digestive nodes and deep cervical nodes. Usually bacterial 50%, usually Streptococcus. And the indication of tonsillectomy includes a recurrent acute tonsillitis, suspected malignancy, enlargement causes sleep apnea. Dissection tonsillectomy is preferred technique with hemorrhage being commonest. Complication delayed. Otalgia may occur in the glossopharyngeal nerve related সমস্যা. So that is all. So that is all about today's presentations. I hope how you feel to see these kind of lectures. I hope it will give you some anatomical knowledge or important topic related knowledge of head neck, also the whole anatomy. So this is the last class of anatomy. So you all see these videos time to time, and give your best in the MRCS and the past test question bank to correlate how many knowledge you have gathered and what are the practical implications you can done in the exam period. That is very important. So thank you very much. So that is all about the classes. In the next classes we will going to start the physiology or physiological videos in 3 to 4 lectures. So I hope keep watching, and I also like my channel, and the subscribe button, please press on. And if you want to keep attached with me and keep studying MRCS Part A, and later on if I pass, then I will give some MRCS Part B videos also. Thank you very much for patient sharing. Peace.